Collar skin respiratory distress is here.
Right.
You okay?
Yep.
Nick Bradley, 19, found unresponsive by parents. No meds, no allergies. On arrival, he was barely breathing with pinpoint pupils, bradycardic at 38.
Bradycardia means a heart rate below 60. Normally, the heart rate is 60 to 100 beats per minute. Below 60, we call it bradycardia. Above 100, we call it tachycardia. Pinpoint pupils means that the pupils are abnormally small and constricted, typically less than 2 millimeters in diameter. Given the history of a young patient with low heart rate, respiratory rate, and pinpoint pupils, this could indicate an opioid overdose. Opioids include the class of drugs like morphine, heroin, codeine, and fentanyl. The other cause of similar symptoms could be that there could be head trauma, which could involve brainstem, especially the pons. Now, this could be a stroke or herniation. Another catch is that since the parents found him unresponsive, this might indicate that there was no history of trauma to the head. So I would naturally lean more towards the opioid toxicity here, meaning drug overdose, but let's see further.
Pupils responded to Narcan.
Now, this finding is absolutely crucial. Narcan is the brand name for a drug called naloxone. Naloxone is an opioid antagonist, which means that it's a medication used to reverse the effects of opioids. Just from initial assessment of the patient, somebody guessed opioid overdose and gave this drug immediately. The pupils responded to Narcan, which means that after administering this drug immediately, the pupils got dilated. This might indicate that this is a case of opioid toxicity.
But we tubed him when his respirations didn't pick up.
Tubed him means the patient was intubated. And yes, opioids do cause respiratory depression and respiratory failure. Endotracheal intubation is a measure of securing the airway when there is respiratory failure, which means that the patient's respiratory rate and oxygen saturation wasn't picking up or improving, even with supplemental oxygen given. We can see that the patient is intubated here. This is one end of the tube connected to an ambu bag connected to supplemental oxygen. The other end is placed and sealed onto the trachea inside to directly supply oxygen to the airways and lung and assist in respiration.
Any drugs or alcohol on the scene?
No,
Signs of trauma?
nothing.
Okay, open your eyes, Nick.
Where was he found?
In bed by his mom.
Pupils are 6 millimeters, non-reactive.
Heart rate 64, BP is cycling.
This indicates that the vitals have improved upon administering Narcan, which is a good sign. The pupils are 6 millimeters, non-reactive, means that the pupils have stayed dilated, fixed, and unresponsive to light, which is not a good sign though. And it does hint at brainstem injury.
No response to pain, GCS-3.
GCS means Glasgow Coma Scale, used as an assessment tool to measure level of consciousness. A GCS of 3 means that the patient is in the lowest possible level of consciousness, signifying a comatose state, with the patient being completely unresponsive to stimuli, no ocular, verbal, or motor response to stimuli.
Does that fit any toxidrome?
No. If it was just opiates with Narcan, he'd be breathing on his own.
I mean, doesn't it depend on the dose of the opioid intake though? Narcan can reverse respiratory depression, but still, if the dose was too high, Narcan alone won't reverse severe respiratory depression, and intubation is required in such case. If the patient has adequate spontaneous breathing after naloxone, intubation is not needed. If respiratory depression persists despite naloxone, intubation may be required. But maybe there are some other causes and we are wrong on the provisional diagnosis. Let's see.
Beta blockers shouldn't give pinpoint pupils.
Beta blockers refers to drugs like propranolol that are used for heart conditions. This could be after a heart attack to prevent arrhythmias or cases of anxiety disorders or essential tremors. But they don't have effect on pupil size, which is mainly regulated through alpha adrenergic or cholinergic receptors, not beta receptors.
Maybe parents had some prescription meds in their bathroom.
They're on their way.
That's a stand-up scooter rider versus car door, no helmet.
No blood in the belly, no pericardial effusion, and lungs are up.
Sometimes there are no overt signs of trauma outside, but there could be bleeding and organ damage inside due to blunt force trauma. Just to rule out the possibility of trauma, she's performing a fast scan, which is a quick ultrasound scan done bedside in cases of trauma, to look for free fluid collection in the body spaces, like for example in the pericardium surrounding the heart, which would be pericardial effusion, in the pleura surrounding the lungs, which would be pleural effusion, and in the abdomen, which would be peritoneal effusion. CT scan of the head and whole body would also be ordered, as it would give even more detailed assessment of brain injury if present, or any internal bleeds or fluid collections, or any organ damage if present. As we've said before, traumatic brainstem injury involving the pons. Although history isn't suggestive of trauma,
HemoQ's good, 15.
this means hemoglobin level is 15, which is normal. It could have been decreased in cases where there was internal bleeding. This means there's likely no internal bleeding.
BP 84, we're 58.
Okay. What's your plan, Dr. Collins?
Push dose epi, 0.1 milligram. Foley for urine, stabilize for CT, and throw a wide net.
The case just got interesting. The patient's BP is crashing. The patient is in hypotensive state with low heart rate. In such case, epinephrine or adrenaline could be given that increases the patient's heart rate, cardiac output, and BP. Since the patient has a GCS of 3, Foley's catheter is to be used for draining urine, as unconscious patients aren't able to urinate on their own due to loss of bladder control.
Where are we going now?
We need the room for someone else, but you can rest in the hall till we get your labs back.
The patients in the most critical state in the red zone are prioritized more than the stable ones who are put in the green zone of the ER. Stable patients are either planned to be admitted or discharged immediately or requested to wait in case of pending investigations, and in this case of unavailability of beds, even in the green zone, requested to stay outside in the hallway.
Systolic back down to 90.
Another 0.1 of epi.
Flaccid paralysis of all 4 extremities.
Epinephrine could be repeated like this as a bolus, or an infusion could also be set up to continuously provide epinephrine and titrate the dose as we go until the patient's vitals become stable, with increase in BP and heart rate back to normal. Flaccid paralysis means that there is reduced or absent muscle tone, with weak limb muscles usually caused if there is injury to the lower motor neurons. There is another type of paralysis called spastic paralysis, which means there is increased muscle tone and reflexes with stiff muscles, usually caused if there is injury to the upper motor neurons.
No eye movement with ice water.
So no brainstem function.
This test is called caloric reflex test. Here, when cold water is poured into the ear canal, it causes the temperature of the fluid in the inner ear to drop, which stimulates the vestibular system of the ear that in turn triggers eye movement. This process involves the brainstem. Here, when cold water is applied to the right ear, normally the eyes would initially move to the right and then back to the center. This reflexive eye movement is called nystagmus. If this movement doesn't exist, like in this case, it means that there is inadequate brainstem response, which might indicate brainstem injury, that is, injury to the pons or the medulla, which lodge the vestibular and oculomotor nuclei responsible for this reflex. Interesting thing to note here is that if the brainstem injury is suspected, there would actually be spastic paralysis rather than the flaccid paralysis here, because the upper motor neurons pass through the brainstem. Flaccid type of paralysis could actually occur if the spinal cord is damaged, which involve the lower motor neurons. Let's see how this case turns out.
Due to?
Hypoxic injury, massive hemorrhage.
There are basically 2 types of strokes. One could be due to decreased blood flow or hypoxic injury called ischemic stroke. The other could be a brain hemorrhage called hemorrhagic stroke.
Samira, escort him to CT. Take the drug box with you.
Call me if you need me.
68-year-old male, history of hypertension, 1 hour of right upper quadrant pain after eating a fatty meal, now resolved. Afebrile, non-tender. There was a gallstone present on POCUS.
I must say the guy is quite smart to have spotted a gallstone on ultrasound right away as a med student.
EKG shows no acute ischemic changes, but I'm still waiting on LFTs and lipase.
Why did you order the EKG?
The nurse suggested it to rule out any cardiac issues.
Well, good call on both your parts. Nurses know what they're doing. Never hesitate to listen to them.
This reminds me of when I was doing internship in the hospital, freshly after final year of medical school. We used to be rotated in the ER every once in 5 days. Initially starting out, we didn't know any better, and most of what we learned from asking nurses who had worked there for several years. The senior nurses do definitely know a lot more than doctors starting out, having seen cases every single day for years. They often correct doctors in decision-making and diagnosis. Sometimes, when the doctor in charge of the ER was busy, nurses would start medications for pain and symptomatic relief by themselves and would only consult doctors for further evaluation of the cases. So, a lot could be learned from nurses, not only in the ER but also in the ICU and all the other wards. After all, medical practice is a coordinated teamwork from doctors and nurses and every healthcare provider involved, so there is something to learn everywhere from everyone, which makes medical practice interesting every day at work.
Your father has pneumonia. and a condition called sepsis.
Sepsis refers to body's exaggerated response to an infection. Usually there is a primary source of infection, like the lungs having pneumonia in this case, and then the organism spreads from there to the bloodstream and then to different organs, potentially causing organ failure. Or there could be widespread inflammation from the release of inflammatory mediators from the source of infection as well.
What is that exactly?
It means that the bacteria has spread from his lung to his bloodstream.
This particular spread in bloodstream is called bacteremia, and if the organism multiplies in blood, it's called septicemia.
So far, he's been responding well to treatment. So your father came in with low blood pressure, which is improving.
Can he go back to assisted living?
Eventually, we hope so. Your dad has an advance directive expressing his wishes, which says that IV fluids and medications are okay, but no artificial life support, no CPR.
So, his advance directive includes do not resuscitate or DNR and DNI or do not intubate, which means that if he experiences cardiac or respiratory arrest, no attempts should be made to resuscitate him like CPR. But comfort care is to be provided, including IV medications and fluids and oxygen as well, but again, no mechanical ventilation via intubation if he goes into respiratory failure.
He doesn't want a bunch of machines keeping him alive.
Okay. Then we will continue with oxygen and IV fluids and antibiotics. But if his lungs stop working, we're not going to place a tube in his windpipe for a breathing machine.
This sounds like a do not resuscitate. Comfort care, where the comfort care will be given, but in the event of respiratory failure, no intubation, and in the event of cardiac or respiratory arrest, no CPR shall be attempted. The thought that a patient would want not to be poked and tubed and put on a machine when they have reached the end stage of arrest is pretty understandable.
But pneumonia is treatable.
Most of the time it is.
Pneumonia is curable, however, if it's spread throughout the body causing sepsis and organ failure, or has complications in the lungs, or is resistant to the highest grade of antibiotics. It can very well lead to respiratory or cardiac failure and death. In fact, I have seen more deaths in the ICU from organ failure related to sepsis, where the primary infection was pneumonia to begin with, than any other case.
But if he can get better in a week, then put him on a machine.
That's not what he wanted.
This is such a misconception. Putting someone on a mechanical ventilator doesn't mean he would necessarily improve quicker and faster. In fact, successful extubation in a case of a critically ill patient who was intubated is actually not as common as is expected. If the patient is critically ill, from just my experience, and this is not statistics, there could be a 50-50 chance that they would or would not return back to normal breathing after being put on ventilation.
If things get worse, sometimes allowing for a comfortable natural death can be the most humane path.
This sort of advance directive actually allows for a peaceful death, and this comes after seeing several patients dying while being on a ventilator and not waking up despite several attempts of CPR. So, it's rational that some patients would not want that to happen to them at their end of life and would rather want to depart peacefully.
No routine cases until we assess the tier 1. Thanks.
This reminds me of when patients who could actually be managed from the OPD used to come to ER, despite the ER being full of tier 1 or critical patients, on a holiday where the OPD used to be closed. ER isn't really for routine cases that could be managed on an OPD. It's for the emergent or serious cases that would worsen if not provided immediate help.
A 36-year-old woman with severe headache due to paracervical trigger point.
Paracervical trigger points are hyper-irritable spots in the muscles surrounding the cervical spine like sternocleidomastoid or trapezius. These trigger points are small, taut bands of muscle fibers that can become painful, usually due to poor posture or excessive muscle strain. These points refer pain to other areas, such as the head, shoulders, and upper back, due to shared nerve roots with these muscles. In this case, the pain is being referred to the head, causing headache.
Her pain went from 11 to 0 after 2 cc's of IM Marcaine.
Marcaine is the brand name of an anesthetic drug called bupivacaine. These injections help by numbing the affected muscles of the trigger point and nerves, reducing pain sensation there, as well as the referred pain to the head.
Wait. You did a trigger point injection before presenting the case?
Yeah.
Interns always present first.
I spent a month at the pain clinic.
No, it's not okay.
Yeah, so it's always safe to ask a senior doctor first before performing any procedure or before writing down medications in the ER as an intern. Sometimes we think we know and become confident to do things on our own, but due to lack of experience or necessary expertise, we might miss out on other comorbidities of the patient and end up harming the patient. So this could turn disastrous, and it only takes one mistake to haunt you forever in the ER. One example is a case where the patient had pulmonary edema or fluid in the lungs. Lasix or furosemide, a diuretic drug, was given, but without checking blood pressure and creatinine levels by an intern. The patient landed in hypovolemic shock, and he was immediately rescued by the treating ER physician who stopped it. The intern got scolded pretty badly, and I am sure the guilt of it stays with you forever.
It's definitely not okay.
23-year-old Ben Kemper, no helmet, got doored riding an e-scooter. Neck versus handlebar, then face planted to the pavement. Obvious facial fractures, but alert and oriented with good vitals.
How we doing, Ben?
Blood. Back in my throat.
That's probably from the nosebleed.
Yeah, a case of posterior nosebleed would cause blood in the throat, because the blood flows back from the back of the nose into the nasopharynx, where it may be swallowed or spat out. Also, we can see they are doing suction to clear out the blood from the mouth and pharynx. This is an important measure to clear out the airway, the A in the ABCs of emergent care.
Short rapid rhino, please.
Tachy at 120, pulse ox borderline at 90.
Blow by at 15 liters for now.
Here, the thing to note is that the oxygen saturation is low at just 90. Normally, it's above 95. Blow by at 15 liters means that the oxygen supply should be kept at 15 liters per minute to help improve the oxygen saturation. 15 liters is the maximum limit given via non-breather mask. However, saturation can improve with suctioning done here as well if the patient's low oxygen levels are due to airway obstruction caused by blood.
Neck contusion, larynx shifted to the right, no crepitance.
Laryngeal shift means the shift of larynx from its normal position due to trauma here. There's nothing else to it. However, there's another term called tracheal shift or deviation. Tracheal shift refers to the displacement of the trachea from its normal midline position. For example, if it's shifted to the right, it could indicate either lung pathologies like collapse in the right lung, or in the left lung, there could be pathologies like tension pneumothorax, where air gets trapped inside the pleura, or collection of blood in the pleural space called hemothorax. These could be relevant pathologies in any case of trauma, so palpation for checking tracheal shift is important. Crepitance or laryngeal crepitus means a crackling or grating sensation or sound felt or heard when the larynx is moved from side to side. It's a normal phenomenon, but its absence indicate reduced mobility due to mass or swelling or hematoma or even laryngeal fracture, all of which could be relevant in this case of trauma.
More morphine.
Pain management is often neglected in the case of trauma. Morphine is a potent opioid analgesic used for moderate to severe pain.
I'm gonna stick something in your nose to stop the bleeding.
No hemotympanum.
Hemotympanum means blood in the middle ear. This could be ruled out using an otoscope to view the tympanic membrane of the ears. The presence of hemotympanum is typically seen as a dark, blood-tinged or brownish appearance behind the eardrum.
Inflate the balloon.
The balloon being referred to is a nasal balloon catheter, like a rapid rhino, which is used in case of posterior epistaxis or bleeding from the back of the nose. Insert the deflated balloon inside the nose, and inflating it would provide a tamponade effect on the bleeding vessels and help control bleeding of the nose.
How about now, Ben?
Better.
What's up?
Good vitals. A and O. Let's have a look.
A and O means alert and oriented.
Ouch. Floating face.
Lefort 3 fracture.
Lefort fractures are specific classified patterns of mid-facial fractures from the skull base. There are 3 types of Lefort fractures. Type 3 is the most severe type, where the midface completely separates from the skull base, hence also called craniofacial separation, or floating face, implying that the midface is floating as it's separated completely from the skull, making it movable. As this resident palpated, the midface moved extensively. There was gross displacement of the midface relative to the skull base. This sort of abnormal movement is possible only if there is Lefort type 3 fracture, where the midface is no longer firmly attached to the skull base.
You don't see that every day. Okay, let's prep for an airway. Double setup just in case.
Double setup is a term used in airway management. Since maintaining oxygen saturation has been a struggle here, the best way to secure the airway in such case is to intubate, also called endotracheal intubation. As said in episode 1 as well, this involves inserting a tube called endotracheal tube into the trachea, ensure proper ventilation and minimize the work of breathing for the patient. However, since this is a case of severe blunt force trauma, the anatomy of the airway could be altered. Swelling, fractures, or bleeding can obstruct the airway or make it harder to visualize the airway and vocal cords during intubation. In such case, there should be set up for equipments necessary to make a surgical airway by performing cricothyrotomy, which means making an incision between the cartilages of the larynx to surgically access the airway.
Ketamine and sucks on board.
Pulse ox holding at 94. Prepping the neck just in case.
They're trying to intubate the patient here. Ketamine and sucks, or succinylcholine, are drugs used during general anesthesia, which is required prior to intubation. Prepping the neck just in case means they are preparing for cricothyrotomy or surgical airway access, just in case the intubation fails if the airway can't be visualized.
Let's have a look. A little deeper.
Lots of swelling. I can't see the cords.
To the right. The left. Yeah, really distorted from the trauma, and the edema is only going to get worse.
So, for intubation, we put the tube in between the vocal cords. We have seen successful intubation in the breakdown of the first episode of the series. Go watch it if you haven't already. Now, if the vocal cords can't be visualized through a laryngoscope, we can intubate the patient. As we said before, here firstly, the anatomy of the airway is distorted due to swelling and blunt force trauma. And secondly, due to blood, the vocal cords can't also be visualized. Hence, intubation isn't possible here. Maybe a cricothyrotomy, I guess. Let's see further.
Which is why we should crike.
You don't crike a laryngeal fracture. Don't listen to Edwina Scissorhands here. If they can't cut it, surgery doesn't know how to fix it.
Okay, so it's revealed that there is fracture of the larynx, which means fracture of thyroid or cricoid cartilage or both. In such case, the anatomy of the larynx is distorted. So, it's difficult to accurately locate the cricothyroid membrane, and it is this membrane where the incision is given to place a tube. Also, inserting a tube through a fractured larynx anyway may worsen the already distorted anatomy of the airway, causing airway collapse. So the risk, benefit, and the urgency of the situation are to be assessed here. I would guess the safer option available here is tracheostomy, where incision is given a bit below in the trachea, making an opening in the trachea from outside.
Contusion is high at the thyroid cartilage, so you just stand there looking pretty, ER Ken, and let me fix this.
We're down to 85.
All right, pull out iGel, bag and crike.
So, the laryngeal fracture was a bit higher in the thyroid cartilage, which means the cricothyroid membrane was intact, I guess, and so they went ahead with the cricothyrotomy. iGel is a single-use supraglottic airway device which has a non-inflatable cuff. It differs from LMA used and described in the first episode in that LMA is reusable and has inflatable cuff. iGel is basically a one-time use, which is easier and faster to insert. The iGel is typically connected to a bag valve mask or ambubag to provide positive pressure ventilation, being referred to casually here as bag.
Please.
Turn off the alarm.
I've never done a crike before.
No, Mel will do the crike. You've already had a busy morning. Glove up, Mel.
No, I'm doing the crike, doctor.
You would be doing it, doctor, if it wasn't an odd day. Surgery gets even days, ED gets odd days. You know this. For crike's sake.
It's because you're all odd down here.
Okay, so this is a typical turf war between the emergency and the surgery residents as to who's going to do the procedure in the ER. Usually everybody wants to do procedures, and there's competition for that among residents.
Okay, teamwork, please. Let's focus on the patient.
I so appreciate your gracious understanding.
I'll assist in case she screws up.
Yolanda, play nice.
That's a pretty salty resident to another resident.
Stats are up with the iGel.
You ready? Hello?
Hello.
You've done this?
Yes, in the cadaver lab.
There will be a lot of first times in procedures, especially as a junior resident or an intern in the ER.
Let's hope that's not where this poor soul ends up. We'll do an open technique since we have a minute.
Okay. Okay, you're going to be making a vertical incision to avoid the jugulars and the carotids.
Basically, a perfect midline incision would avoid the carotids and jugulars.
Good. If this was a crike that needed to happen in seconds, you could use a 10 blade, your finger, and a bougie.
I mean, this incision is way longer than it should have been. Basically, the incision given is a vertical incision 2 to 3 centimeters over the cricothyroid membrane and a horizontal incision 1 to 2 centimeters through the cricothyroid membrane. The girl here has given such a long vertical incision that it likely reached up to the sternum here.
This is called a Wheatlander, and this is your tray cook.
C-spine, head CT, OMF, start a propofol drip.
Propofol is the name of a general anesthetic drug to be supplemented here for this procedure.
Okay, now we're going to make a horizontal incision across the cricothyroid membrane.
4-0 Shiley next. Get ready to bag the Crike.
Yeah. Good.
Here, the cricothyrotomy tube has been inserted in the surgical opening. This is the other end of the tube, which is to be connected to the ambu bag immediately for ventilation, so an assistant is required to be ready with the ambu bag.
Oh, excuse me. No worries. End tidal CO2 is yellow.
Yellow is yes. Nicely done.
We measure the end tidal CO2 using a colorimetric device fit onto the end of the tube. A color change from purple to yellow indicates that the exhaled CO2 level from the device is above 2%, suggesting that the cricothyrotomy tube has been properly placed in its position.
Sew it in. Okay. I will be next door.
Does your resident know how to suture, or do I need to teach?
Again, a very condescending remark. Also, from my personal experience during internship, the residents of surgery were typically very condescending and toxic, some with God complex.
You're all class, Yo-Yo.
I know. Thanks.
Just received word your son's head CT is normal.
This means that our second guess of traumatic head injury has been ruled out. No intracranial bleeds or herniation or anything. Means I can only think of one thing here: opioids.
And he's maintaining a good heart rate.
You got him back.
Blood pressure.
Thank you, thank God.
Right now, he's unconscious with a tube in his throat for oxygen. Why don't we step out for a minute while they get him settled, and then you can come back. You can sit with him as long as you want.
Nikki, it's Mama. I'm here, babe.
You're doing great, son.
Blown.
So, the boy had pinpoint pupils before, then he had dilated pupils with naloxone reversal, but the problem is that it stayed dilated till now, with no response to light. This is called a blown or blown out pupil, which again should hint at brainstem injury.
Okay, let's step outside. Okay. So, we don't know how long he was at home without breathing.
He's breathing now.
Not on his own.
But he's gonna wake up.
We certainly hope so. We're gonna know better after we get some more test results back. Are you sure that he didn't take anything that could have caused this?
No, he's a good kid. He's in college. He has a part-time job. He even chose to live at home so he can focus on school.
Dr. Robbie, from the urine.
What's that?
It's a drug test, and it is positive for fentanyl.
All right. So opioid toxicity was right after all. Naloxone couldn't bring back breathing because either the dose was high or a lot of time had already passed after the intake, leading to respiratory failure, severe hypoxia with dropped oxygen saturation, at which point ventilation is the only life-saving measure left. Trauma was never the likely diagnosis, and the brainstem injury eluded so many times with blown pupils, negative caloric reflex test, likely resulted from the fentanyl overdose, causing respiratory failure, hypoxia, and hypoxic injury to the brainstem.
No, that isn't possible. Nick doesn't do drugs.
There are a lot of pills that are sold illegally that have fentanyl, not just painkillers. Xanax, Ativan.
Xanax is a trade name for alprazolam, while Ativan is a trade name for lorazepam. Both are under the drug class benzodiazepines. Xanax is short-acting and is commonly used to treat anxiety, while Ativan is used for the treatment of seizures. In recent years, some black market pills, including counterfeit Xanax, have been found to be contaminated with fentanyl. Fentanyl is a powerful synthetic opioid, up to 50 times stronger than heroin and 100 times stronger than morphine, and its presence in counterfeit drugs is a significant public health concern due to the risk of overdose.
No, not our son.
Well, maybe he didn't know that he took something with fentanyl. I don't know. The hows and the whys don't really matter. What matters is spending time with Nick. We've got some more tests to run. We'll know our options after that. But in the meantime, why don't you take a seat, talk to him?
Can he hear us?
You know, we're never really sure, so you should just assume that he can. And we'll come find you as soon as we know more, okay? Can we move Nick Bradley to a private room?
Like you're gonna make it? Didn't you respond to Narcan?
I think his pinpoint pupils just grew into blown pupils from brainstem death.
That's what I thought about as well. The response to Narcan was a tricky one. Either it was an actual response to Narcan, but due to the high drug dose or delay in arrival, it was actually too late for Narcan to reverse toxicity. Or more likely, as Dr. Robbie alluded, the high drug dose or delay in arrival had already caused severe respiratory depression and failure, so much so that there was severe hypoxia and hypoxic damage to the brainstem. The brainstem controls the pupillary and caloric reflexes, so these were negative as the brainstem tissue had died.
Shit.
Yeah, not much older than Jake.
Don't go there.
Hard not to sometimes.
Mr. Spencer's room.
What is happening?
His oxygen levels are dropping. Mr. Spencer, how are you feeling?
I don't remember where I parked.
Mr. Spencer, do you know where you are?
It's so loud in here.
Dad, do you know where you are?
Dad, look at me. What's my name?
I don't know where my car is.
We can see that his heart rate is high, his blood pressure has dropped likely due to low cardiac output, his oxygen saturation is dropping. This is trying to depict a picture of cardiac and respiratory failure. Also, we can note that he has nasal prongs. Typically here, we would change the oxygen delivery from nasal prongs to a face mask or a non-breather mask and see if the saturation improves or not.
IPAP 15/5.
If the oxygen saturation doesn't improve via a non-breather mask going at 15 liters per minute, then we would switch to non-invasive ventilation, which would involve BiPAP or bi-level positive airway pressure. This is an interesting one as here we provide two different airway pressures at the two stages of respiration, the inspiration or inhalation where higher pressure is applied to deliver oxygen to the lungs, and expiration or exhalation where lower pressure is applied to prevent the airway or lungs from collapsing. BiPAP 15/5 means that the inspiratory and expiratory pressures to be given are 15 and 5 centimeters of water respectively. If airway collapse is a major concern, then there is CPAP or continuous positive airway pressure as well, where the same continuous pressure is applied at both levels of respiration so that the airway doesn't collapse.
What's BiPAP?
It is a pressurized air mask that can improve his oxygen.
Now you might be thinking, where does intubation and ventilation fit into all this? Well, the next step, if he doesn't improve with BiPAP, should ideally be mechanical ventilation via intubation. However, due to the advanced directive being signed, it won't be performed. He would be provided oxygen, and if he goes into respiratory or cardiac arrest, no CPR or defibrillation or epinephrine or intubation to resuscitate him.
Either his pneumonia is getting worse or his heart couldn't handle the fluids that we gave him to treat the sepsis. His lungs are filling up with fluid.
Can't you take the fluid away?
Not without his blood pressure crashing with very bad consequences.
Fluid in the lungs means pulmonary edema. So we are looking at either a case of acute respiratory distress syndrome caused by septic shock due to pneumonia, or we are looking at left heart failure where the left heart is unable to pump blood into the body. On one hand, his cardiac output is declining, while interestingly, on the other hand, the blood in the left ventricle can't empty. So there is backflow of blood from the left heart to the lungs, which causes pulmonary edema. So pulmonary edema here can indicate both respiratory distress or left heart failure. We call it non-cardiogenic and cardiogenic pulmonary edema, respectively.
So let's just hope the BiPAP works.
And if it doesn't?
Then I would need to know your decision about using a breathing machine.
We're still talking about it.
Well, we know he expressed his wishes in writing. Do not intubate.
If the patient has already signed a DNI or do not intubate, can the family members legally insist in doing so against the wishes of the patient?
We're thinking try it for a week.
That would be a very painful week. He wouldn't get a lot of rest with all the monitors and all the blood tests. He might need to be sedated. He might need to be restrained because he'd be in an unfamiliar place with a very uncomfortable tube down his throat. And he wouldn't really know what was happening.
Yeah, so it's not a peaceful way to die at the end stage of your life, and I have seen such deaths in the ICU. Also, isn't the very purpose of signing an advance directive or DNR or DNI to specifically avoid such traumatic, painful, uncomfortable, and unpeaceful end to life? And the worst part is patient has no clue he's even in the ICU as he's heavily sedated, and patients die as such, never waking up and being extubated.
Elderly patients can often develop psychosis.
People often say psychosis, but it's actually more appropriately called delirium. It's an acute confusional state where the patient is disoriented and doesn't really know what's happening. And yes, it's common in the ICU due to prolonged ventilation and sedation, which the patient here definitely could suffer from if he is intubated.
But he might get better.
Or he might get worse. What would you do?
I really can't answer that for you. This is your father. That's your decision to make. I can guarantee you that we will keep him as comfortable as possible if a natural death is what you choose.
But he's not your father. And he can recover from this.
What my sister means is that we're still deciding the best thing to do.
Well, the sooner you decide, the better. I'm really sorry. I wish there was more that I could do. I'm not sure that he has that much time left.
Delivering sad news to the patient or negative counseling in a critically ill case beyond recovery is always hard and takes an emotional toll at the doctors as well. We can't directly state you should do this or this is appropriate. The ultimate decision rests upon the patient and the patient party, but ultimately rests on the patient, who in this case has already signed a DNI, by the way, stating he doesn't want to be intubated. The patient party is in a dilemma. What if intubation helps him get back is the question, but it might get worse too. One thing is for sure though, it won't be a peaceful death if death were to occur in the ICU.
That's the thing about emergency medicine. You never know what you're gonna get, and we get everything.
Is that why you chose it?
Maybe a little. I also get to pick my shifts, which for a single mother is amazing. But mostly, I just like the people, you know? They're always there when you need them. You wouldn't want to be a part of that, you know?
This is the monitoring center. We see that you're not in your inclusion zone. Do you have permission to be outside this area?
Yes, I am at work. Just like last time and the time before that.
Is this some sort of a tracking device that monitors where residents go so that they are on their duty and haven't escaped the hospital or something? That's pretty crazy, if this is the case.
Sorry.
You're doing great. Take your time. You okay?
I get frustrated when I can't do things, or at least it looks like it.
They're suturing the tube onto the patient's neck to seal it there. I think everybody has experienced this imposter syndrome, especially in situations like emergency where you gotta show up, and if it's the first times of anything, you are gonna screw up a little. Just what the seniors would say or think about me screwing up, this fear alone engulfs you at times. You just gotta push through this feeling every single time. I think this applies to anything in life, in general.
Yeah, you and me both.
Thanks, but my frustration manifests itself emotionally, and then I get upset, and then it looks like I can't handle things, and, then I can't cry in front of the patient because no one wants to see their doctor cry. That's just a big red flag.
I can resonate to this completely. When you don't really know things, but have to act like you know things in front of the patient in order to avoid secondhand embarrassment. Sometimes you get overwhelmed by your mistakes and you have to conceal your emotions in front of the patient because they don't want to be treated by someone emotionally weak, or they could feel like the doctor doesn't even know his stuffs. You just gotta push through it until you become an attending, I guess.
You just did a perfect Craig. You're doing great.
Got an unresponsive, unhoused man coming in. Might be a good teaching case, funky music. Let's go.
Caucasian male, approximately 60 to 70 years old, found unresponsive. No signs of trauma, no ID.
Did you take anything?
Smell the alcohol from here.
This guy's wearing the spring, summer, and fall collection.
Jeez!
What the?
What's wrong? What's going on?
Patient tested positive for rats.
That's really funny. The patient is an alcoholic who got so drunk and disoriented that he probably ended up in a pit or ditch infested with rats the whole time until he was discovered and brought to the ER.
Because your son tested positive for THC, the psychoactive ingredient in cannabis, we're gonna have to admit him for overnight observation and monitoring.
If you haven't seen episode 1, we covered this case of accidental poisoning where the child mistook a cannabis gummy as a normal gummy and took it unknowingly. Tetrahydrocannabinol, or THC, is the primary psychoactive compound in cannabis. Due to its depressant effect on the central nervous system, the child is heavily sedated and unresponsive. This requires constant monitoring of vitals, so the child needs to be in the ER, especially when we don't know how much he took. The respiratory depressant effect of THC is dose dependent.
What about his brain? Is there a chance that much pot is going to do some damage? I mean, he's only 4.
The honest answer is we don't know. There haven't been any long-term studies, but the fact that this is a one-time occurrence suggests that there should be no long-term effects.
Not only that, it also depends upon the individual patients. Some patients have mild presentation with the same dose, while others could have severe or sometimes different presentation than others. This occurs with any drug, and so we can't correctly say that a patient won't have certain symptoms or effects because everything and anything is possible at any moment.
But you don't know. So my son could end up with learning disabilities, psychiatric problems, or even autism because
there's no evidence to suggest any of that.
I don't like when patient party is rude to us like this. We are always there to help with as much information as we know and can do. Doctors can't predict the course of any disease, disorder, or toxicity of drug. Rather than giving false assurance, we gotta say as it is, even if the patient party doesn't want to hear it. The emotional outburst here towards the treating doctors is unjust.
Hello, I'm Kiara Alfaro.
I'm the department's social worker.
Kiara will help you navigate the next steps.
What steps?
Well, a case like this requires mandatory reporting to child services and sometimes law enforcement.
No.
Why do you have to involve the police?
It's a controlled substance.
If a child accidentally ingests such stuffs due to poor supervision, the Child Protective Services would have to be involved. The case of accidental poisoning becomes medical legal if there is suspected negligence from the parent's side, and it involves vulnerable population like children who don't know any better. So, a medical legal investigation can be required to ensure there was no abuse or negligence.
They're not taking my kid away.
They were pot gummies.
Well, suggestions. No one is touching my child. In fact, we're leaving.
Well, you can't take your son. He could stop breathing. He could have
I'll
a seizure.
observe him at home.
Amanda?
Not a wise move from the mother trying to take her child and leave against medical advice. The child could have respiratory failure and stop breathing, meaning respiratory arrest. He could have extreme confusion, hallucinations, delirium, uncontrollable vomiting, severe drowsiness, or even seizures, or could land up on coma if the dose was very high. All of these can't be treated at home, thus requires hospitalization.
If you can't cooperate, I'm going to have to ask you to leave.
Amanda, please. He needs to stay here.
And you need to get out.
Your son can't leave the hospital, but I can have you removed.
Don't you dare touch me. Get out! All of you!
Usually patients who are aggressive or violent in the hospital against the healthcare providers are totally sane individuals. We often tend to believe that psychiatric patients are the violent ones, but only few cases are like that. More often, sane people are the ones that snap and act like this.
Gotta see why I
Amanda!
Okay. This is a hospital. This isn't the Jerry Springer show.
Hospitals have other patients too who are critically ill and in severe distress. Hence, a peaceful environment is a must.
Ma'am, nobody's trying to take your child. So why don't you stay here with him while your husband talks to our social worker outside and straightens all this out?
Well, I don't want him speaking for me and my son.
Well, it is either you or him.
Parents are the ones who can take medically important decisions for their child's treatment and care.
Him. Your son is not leaving, but you can be escorted out and even arrested if you refuse to cooperate. Nobody wants that. So you tell us, what do you want to do?
Yes, so patient or patient party sometimes think we are there to take their happiness away, or we are suggesting some medication or doing procedures not in their best interests. Patients do not trust doctors, even though we are just trying to help as much as we can. We provide options, and the ultimate decision maker is the patient or patient party themselves.
I'm staying with my son.
Okay, great. You do that.
He's not texting back. Oh, I'm sorry about all this.
It's okay. It's okay. What you're doing for David is very brave.
So, as per the previous episode, this was a case of malingering where the mother consciously took Ipecac, an obsolete emetic drug, to induce vomiting and fake an actual illness for some secondary gain, which in this case was so that she would be taken to the hospital by her son and she could ask for help here for her son and give him necessary counseling he needs.
I'm his mother. I'll do anything to protect him.
Do you think he would hurt anyone?
No. I'm sure a lot of parents felt that way before their children did unspeakable things.
Does he have any history of violence? Has he ever been in any trouble?
No, never. He's very quiet. And he takes great care of me. He's struggled with his father's death.
So there's always something that triggers a person to develop ideas of committing extreme acts of violence. And here, it's the death of his father that had a psychological effect on him, likely emotional distress and depression. This can cause increased impulsivity and violent outbursts of emotions, which often results in poor decision-making for oneself and others around. So, the son does need psychological counseling at the very least.
Keep trying to reach him. If you do, have someone come find me.
Okay. Thank you.
Of course. Drug-seeking woman kicked off a city bus for disrupting and disturbing passengers. She's been screaming for narcotics nonstop. We found an empty Percocet bottle.
What are you doing?
Percocet is a brand name for a combination of oxycodone and paracetamol. It's commonly prescribed for moderate to severe pain relief. The oxycodone component here is an opioid, hence is liable for abuse and addiction for its sedative and euphoric effects.
Why can't you hold it?
He's been uncooperative and combative since we picked
Get off her! Let her go!
Stop fighting! The cops.
My meds at home aren't working. Please, I have sickle cell. Okay.
Sickle cell anemia is an inherited disease where the red blood cells, which are normally round, become abnormal and sickle-like shape, under conditions of hypoxia due to abnormal hemoglobin formed that aggregates to distort the shape of the RBCs. Interestingly, what happens is that the sickle-shaped red blood cells obstruct capillaries and restrict blood flow to an organ, resulting in extreme pain due to ischemia, hypoxia, and organ damage. This is called vaso-occlusive crisis, which simply means crisis occurring due to blood vessel occlusion. Now, this can occur in the limbs causing severe extremity pain or in the chest causing chest pain. We can see that this patient is also in extreme pain.
Stop! Everybody stop! Stop! What's your name?
It's Joyce. It's Joyce.
Joyce, is this your sickle cell pain?
Yes!
Pain during sickle cell crisis could be managed with drugs like Percocet, as was used by the patient here. But if it's extremely severe, it might require intravenous opioids like morphine. People thought she was an opioid addict, but actually she was in severe pain and desperately wanted more potent opioids to ease the pain after oxycodone was unable to decrease her pain.
10 milligrams of IV morphine.
You really want 10?
Yes, repeat it in 5 minutes if needed, and she needs a dilaudid drip. This is a vaso-occlusive crisis.
Exactly like we said before. Also, dilaudid or hydromorphone is another opioid drug like morphine, but is 2 to 8 times more powerful than morphine. It's interesting to know that there are other two crises in sickle cell anemia as well. In very simple words, splenic sequestration crisis means the spleen gets massively enlarged due to clogged RBCs, while the aplastic crisis means the RBC production stops, causing life-threatening anemia.
I'm so sorry this happened. It's gonna be okay now. We're safe here. Come on. It's gonna be safe here. I promise. Just breathe. Okay?
Often, patients become aggressive due to severe pain as well. The symptomatic care after assessing ABC and vitals in ER is always relieving patients' symptoms, the most common of which is pain.
Live wire hit his left forearm. Shocked him once for VFib.
So, he had VFib, ventricular fibrillation, which is a type of heart arrhythmia. He had cardiac arrest due to the arrhythmia, so was shocked once with defibrillator to restore the normal sinus rhythm. VFib is the most common arrhythmia associated with electrocution. What happens here is that the electrical current through the body interferes with the heart's normal electrical activity. It disrupts normal cardiac conduction, leading to abnormal electrical impulses and hence VFib. Ventricular fibrillation can lead to cardiac arrest when the heart stops beating effectively, which is signaled when the pulse can't be felt.
Was there a power pole down?
No, abandoned factory. We found bolt cutters at his side. Got electrocuted.
Try to steal copper?
Most likely. Power line fried his arm and the current through his whole body stopped his heart.
It's not that the current stopped his heart, it stopped his heart from beating effectively to the point there was no palpable pulse, at which point it's called cardiac arrest and was defibrillated. If his heart stopped beating, it would be called asystole. At that point, it's also cardiac arrest, but this can't be defibrillated, and the only options left would be CPR and epinephrine, hoping to revive the heart rhythm.
Add a myoglobin and a CK to the labs.
Electrocution can cause skeletal muscle breakdown called rhabdomyolysis. Here, CK or creatinine kinase, which is an enzyme found in muscle, and myoglobin, the muscle protein, are released into the blood. Myoglobin can cause acute kidney injury, so it's important to monitor serum creatinine as well. Constant eye on ECG monitor is to be kept as well, because rhabdomyolysis could cause hyperkalemia or high potassium, and cardiac arrhythmias. This was discussed in episode 1 in detail. So blood potassium needs to be monitored as well, along with renal function tests.
2 liters normal saline wide open.
Dr. Santos, what are we worried about?
Rhabdomyolysis from tissue damage can kill the kidneys. Ongoing risk of cardiac irritability.
It's worth mentioning that the risk of arrhythmias is pretty high here. First, the electrocution had caused VFib already. This could reoccur again, and now the muscle breakdown and increased potassium can also cause VFib or ventricular tachycardia.
Excellent.
AP pads in place.
Guy fell off a telephone pole?
No, he was on a platform.
Boring.
Cut into a live wire.
Hence ventral compartment.
Set up the stick pressure monitor.
The stick pressure monitor is a device used to measure compartment pressure. Basically, muscles are divided into compartments, and sometimes the pressure inside the compartment could rise due to swelling or edema, which could also be caused by electrocution. This is called compartment syndrome, a condition where there is increased pressure within a muscle compartment that could lead to further tissue damage. This monitor helps in the diagnosis of compartment syndrome. Here, the ventral compartment is tense, so the stick needle inserted there would provide accurate measurement of pressure there. High pressure, if present, has to be released to save the muscles from ischemic damage.
VFib.
All right, charge to 300.
Am I running this or are you?
Sorry, reflex response.
Clear.
Another shock of defibrillator. VFibs are recurring. Maybe it's time to put the patient on an antiarrhythmic now like amiodarone.
Ah! Sorry. Sorry. So what happened?
I bought it for my girlfriend's dog. I work nights, and he yaps all day long. And when I woke up, I was wearing it. Stupid. I think she must have used crazy glue.
Have you tried removing the batteries?
Of course. She glued the case shut.
All right, I think we have a couple options, Gary. We can try to find a solvent that will dissolve or at least soften the glue enough for you to peel it off without taking your skin with it. Or,
And your skin cells on your neck will naturally slough off, and you should just be able to remove it in time.
How much time?
Couple weeks, maybe.
Couple weeks?
The thing about ER is that there is literally no shortage of variety of cases. Cases that you would never even expect people would go through or suffer from that come to the ER for help. Sometimes there are solutions, but sometimes there is nothing to be done medically, and all we could provide is assurance to patients. And providing assurance and counseling are very important to do as a doctor, because oftentimes the fear of the unknown would engulf the patient more than the gravity of his situation.
I think this guy's got scurvy.
Was he a pirate?
No, he's an unhoused man. Lives almost exclusively on dollar store ramen. There's parafollicular hemorrhage, gingivitis, bleeding gums, and no fruit or vegetables in his diet.
Perifollicular hemorrhages mean small bright red spots around hair follicles. These hemorrhages occur because fragile capillaries surrounding hair follicles break easily due to lack of vitamin C. These, along with inflamed bleeding gums, bruises, and skin, are signs of vitamin C deficiency, also called scurvy.
Suppose that could do it as long as you've ruled out piracy. No parrot, no peg leg, doesn't reek of sweat and rum.
Well, now that you mention it, there was a smell.
Probably a pirate.
Historically, pirates or even normal sailors used to suffer from scurvy due to long voyages with limited fresh food in the sea. As a result, the British Royal Navy eventually started issuing lime juice to sailors to combat scurvy in the late 18th century, leading to the nickname limeys for British sailors.
Tell him to pick up some vitamin C next time he docks at a dollar store.
I can't tell if you're joking.
No, Captain Scurvy's got a vitamin C deficiency. Cheapest way to fix it is with a daily supplement.
Scurvy can be prevented and treated by having vitamin C-rich foods included in your diet like lemons and oranges.
How's she doing?
Still breathing after 20 of morphine.
Still breathing after 20 milligrams of IV morphine is a subtle jab at the resident who ordered it, because it is a high total dose of morphine given within an hour, since every episode is literally 1 hour. Morphine as an opioid has respiratory depressant effects at high doses. Not only this case, every case in ER where we decide to give morphine, like for example, in a case of severe chest pain due to myocardial infarction or heart attack or cancer patients who suffer from intense pain landing in the ER, we have to be vigilant of symptoms and signs of respiratory depression. Signs of respiratory depression could be respiratory rate less than 8 breaths per minute, shallow or slow breathing, oxygen saturation less than 90, along with symptoms of sedation, confusion, and pinpoint pupils. We gotta check for respiratory rate and oxygen saturation, both before deciding the dose and after the dosing of morphine. Still breathing here means the woman's respiratory rate and SpO2 haven't significantly decreased despite high dose of morphine. However, since the patient has been taking opioid medications, she is probably opioid tolerant.
How's the pain, Joyce?
Oh, a little better.
You've ordered an exchange transfusion.
Exchange transfusion is a life-saving procedure used to manage severe complications of sickle cell disease like vaso-occlusive crisis, also called acute pain crisis, by removing sickled red blood cells and at the same time replacing them with healthy donor red blood cells. The goal here is to reduce the percentage of abnormal hemoglobin called HbS. Normal hemoglobin is HbA. We gotta increase oxygen delivery as sickling is precipitated by hypoxia and hence prevent further complications.
Figured I needed that.
What's your normal regimen at home?
90 of extended release morphine every 12 hours and oxycodone for breakthrough pain, but it wasn't working.
So she is on a heavy regimen involving potent opioids like morphine and oxycodone. However, these are not regular daily medications to be taken for sickle cell disease. They are only to be used for acute pain crises like this one. I guess she was prescribed with these medications to be taken orally at home for episodes of pain crisis, but the pain didn't subside with that. She ran out of medications, and the vaso-occlusive crisis progressed. Severe cases of pain crisis like this must be hospitalized for treatment with IV opioids like morphine and dilaudid or hydromorphone.
Starting IV dilaudid at 4 an hour. You can press this button if you need a little extra.
That only works once an hour, though, so don't go crazy.
So this could have progressed to further complications like chest pain and shortness of breath called acute chest syndrome. There could have been infections or risk of neurologic symptoms suggestive of stroke. So it's always better to come to the hospital in cases of vaso-occlusive or pain crisis for proper management, including oxygen, fluids, and IV opioids, else it could very well progress to such severity where it requires blood transfusion, like in this case, which could have complicated even further.
Could I confer with you?
Yeah.
You seem surprised by the opioid dosage.
Seemed a little high.
So was her pain.
So as we pointed out before, the patient was likely opioid tolerant. These patients could be given higher dosage of opioids for pain relief and only respond with higher doses.
How do you know she's not drug
You
seeking?
can't fake a hemoglobin of 6.
This didn't look like a case of malingering. Malingering means faking symptoms such as pain for secondary gain, which here would be the IV opioids if it was the case. With that being said, faking pain to ask for IV opioids is not an uncommon occurrence at all in the ER. Opioid abusers sometimes come to the ER saying they have intense pain. I actually had a similar experience with a patient who came with severe abdominal pain. He was put on IV hyoscine, an analgesic. He said the pain didn't subside. Then he was put on tramadol, an opioid drug but less potent than morphine. He didn't respond to that as well and was lying in the bed crying. We all thought he was faking the symptoms, but the blood reports came out to have high WBC count along with other abnormalities. He was later diagnosed with a chronic autoimmune condition. He was provided with IV morphine upon consulting with the ER attending at that time. Being suspicious at first about opioid abusers is alright, but further investigations would clarify whether it's an actual case of need of morphine or whether it's malingering. Here, the hemoglobin is 6, which means the patient is suffering from severe anemia. This could be due to rapid destruction of these abnormal sickle cells in the spleen, or could even indicate splenic or aplastic crisis. So, there is a genuine reason to administer morphine for pain relief.
Do you know what sickle cell crisis does to the body? Blood cells get caught and plug up your capillaries and deprive all your cells of oxygen. It's been described as an electrical stabbing pain that feels like it's breaking your bones and flushing glass through your body.
We have already discussed this. I would further add that this pain can occur anywhere, in the bones, joints, chest, abdomen, head, basically all organs, because ischemia or lack of blood flow due to clogged capillaries can occur anywhere in the body.
I never thought of it like that.
Little empathy goes a long way with those suffering in real pain.
Yeah.
Don't worry, you'll get good at spotting the fakers, and half the time all those people need is someone to really listen to them and hear their story.
Yeah, cases of malingering have some sort of motive for secondary gain to be listened to and heard of is a big one.
Anterior compartment pressure is 49.
Burn caused massive swelling.
The normal pressure within a muscle compartment, as measured by the stick pressure monitor, is between 0 and 8 millimeters of mercury. Compartment syndrome is suspected when compartment pressure exceeds 30. Here, it's a lot higher, likely caused by muscle edema due to the electric current, so this potentially requires immediate fasciotomy to release the pressure. Fasciotomy means making an incision through the fascia or covering of the muscles to release the building pressure outside.
What does he need, Dr. Santos?
Fasciotomy.
I like that the names of every procedure and treatment are said here, exactly as would be discussed in a real-life scenario. It's important to note here that it's an emergency procedure, which if not done immediately, can cause muscles to suffer from ischemia, meaning decreased blood flow due to the progressively building pressure inside the compartment. These muscles then eventually die due to the resulting hypoxia. Our ortho attendings used to say compartment syndrome is the only true emergency in case of orthopedics where immediate fasciotomy is a limb-saving procedure.
But he still has a radial pulse.
Pressure'd have to be over 100 to lose the pulse, and at that point, he'd lose the arm.
The pulse reminds me of the 5 Ps of compartment syndrome: pain, pallor or paleness, pulselessness, paresthesia, and paralysis. Out of these, pain is the earliest sign, followed by paresthesia, which means numbness or tingling sensation in the limb. Other signs are late, like paleness of the skin or pallor. Pulselessness or absent radial pulse here occurs when there is enough pressure buildup to severely compress the arteries and compromise arterial blood flow, which occurs late as the pressure soars higher and higher. Paralysis occurs when the nerves are compressed and is also a late sign.
49 is enough to destroy all the nerves and muscles in a matter of hours.
Compartment pressure is 49?
Let me guess, this is an ortho bro, likely an ortho resident coming to check in cases in the ER or someone from the ortho team.
Yeah, gonna make the initial incision down here. Ortho can finish up in the OR.
Good plan. I'll let him know.
So, the initial fasciotomy incision is given in the ER. The definitive fasciotomy would be done in the operating room by the ortho team, where they would extend the incisions as needed, ensure complete release of all affected compartments, and check for necrotic tissue and decide on further wound management.
Sterile gloves for Dr. Santos.
Oh, we don't teach forearm fasciotomies to our residents.
What if she's all alone somewhere someday with no backup?
Every resident should be guided to perform life or limb-saving procedures in the ER, especially an ER resident. There's this culture, which used to be in my own medical school as well, where certain procedures are reserved for certain year residents and the juniors can't even touch. The interns usually look from the distance. This sort of culture should be stopped. Teaching a junior a procedure you know is very rewarding as well.
This is the path to avoid the median nerve and all major vessels.
Maybe just watch the first time.
I don't know about other doctors' experience about this, but watching the senior do the procedure by staying at the side and looking in, I don't know if you'd learn anything. Even if you've watched the procedure 100 times being done by a senior, you don't necessarily learn anything as you aren't the one doing it. Assisting the senior in the procedure, you might learn something, but again, nothing significant. I've assisted in countless cesarean sections. It doesn't mean I could do the operation myself. Doing it once by yourself under someone's guidance makes all the difference. It's all about time and opportunity and heavily depends on how your senior is.
She'll hold the blade, I'll cut. Template of Dr. Santos. We'll start proximal. How much pressure? Just about this much. Through the skin and sub-Q.
This is usually a moment of delight. When a senior is assisting you to perform procedure the first time by literally holding your hands, what more could you expect?
Good.
So, the fasciotomy has been done here successfully and the pressure is being released. This would now be further taken care of by the ortho team in the OR.
I hate seeing families torn apart.
I am a savage, classy, bougie, ratchet, sassy, moody, nasty. I am a savage.
This could be one way to cope up with the emotional stress seeing patients in distress in the ER, I guess, and maybe develop some emotional detachment and become more emotionally strong for the job. This is one way of saying to yourself, I can do this.
I need help. I got stuff.
Can you guys help? What's your name?
Alice.
Oh, I know. All right, we're gonna take good care of you. You guys got it? Up here, Alex. Abdominal GSW in the ambulance bay, code trauma now.
GSW means gunshot wound, which is in the abdomen here.
GSW just got dumped by homeboy ambulance.
Okay, you got this?
Yeah, go.
2 grams of Ansep, orthos on their way.
And Chef is a brand name for cefuroxime, an antibiotic of the cephalosporin class, used here to prevent infection in the surgical site.
Systolic's only 80, 14 gauge, left AC.
We got 2 units of whole blood going on the rapid infusion.
He has significantly low BP and is in a state of hypovolemic shock due to significant blood loss.
Call the OR, we'll be right up.
Lungs up.
Do you take medications every day? Any allergies?
No. Morrison's in full blood. See that?
Yeah. Tore up his liver.
We can see this in the ultrasound here. A torn liver or liver laceration would look something like this. In cases of abdominal gunshot wounds, the small bowel and large bowel or colon are the most commonly injured organs, followed by the liver and intra-abdominal blood vessels. Hemoperitoneum means blood in the peritoneal cavity in the abdomen, caused here by the bullet damaging the internal blood vessels, either of the organs like the liver, or could even be the major abdominal blood vessels like the aorta or its branches or the IVC. This here is visualized via ultrasound, which shows the presence of blood in the body spaces. It would look something like this. as anechoic or dark black collection of blood in the potential space. Here, it's in the Morrison's pouch, a potential space between the liver and the kidney, which is usually the first site of collection of blood during hemoperitoneum. This ultrasound in the scene, is it actually accurate? Because it does seem like blood in the Morrison's pouch between the torn liver and the kidney, and they are even moving the ultrasound probe as well, which still shows the same. The level of accuracy in the series is actually pretty astounding.
What's his name?
Alex.
Alex, you've lost a lot of blood. You need to go to surgery right away.
Yeah, hemoperitoneum is a critical sign, often indicating significant internal injury and potentially life-threatening bleeding. So, it needs to be immediately managed via an explorative laparotomy, which means surgically opening up the abdominal cavity and fixing the source of bleeding by identifying and controlling it. Blood transfusion becomes absolutely essential as a lot of blood has been lost via internal bleeding as hemoperitoneum.
We're gonna die?
Not now that I'm here.
Spoken with humility of a surgeon.
Owen's ready. How's he doing?
He's coming up a bit.
Let's go. You call my mom? She's the ice on my stuff.
Of course, of course.
This is a pretty immediate transfer from the ER to the OR.
So he didn't have to wait for OR?
Nope. We're a trauma center. We always keep one OR stocked and ready to go.
Basically, OR or operating rooms in the hospital are reserved by respective departments, some for general surgery, some for neurosurgery, ortho, and obstetrics, and gynae as well. Having an OR for emergency trauma is pretty good.
Sorry, we had to move you into the hall. I know it gets pretty chaotic and noisy out here. Mr. Milton? Hey, Bennett, wake up for me. Oh, shit. I need a little help here.
The patient has no pulse and has gone into cardiac arrest, likely an asystole, which means a flatline ECG, could be arrhythmias like VFib2. It would be shown by the ECG monitor if the patient was in the ER bed, but the patient is in the hallway. The options here are, if it's the case of asystole, which is non-defibrillable, meaning non-shockable, do continuous CPR along with epinephrine. The dose of epinephrine would be 1 milligram IV, repeated every 3 to 5 minutes. Epinephrine or adrenaline is a potent adrenergic drug which is given to revive the heart, increase heart rate, and cardiac output.
Help!
When did you check on him last?
I don't know,
I don't think this is a correct way of administering CPR. The movement of your hands should come straight from the shoulders with the elbows being straight the whole time, and it should be 5 to 6 centimeters deep. This looked too superficial.
Half an hour ago at most, I was waiting on labs.
What's going on?
It's my gallstone guy. You saw his EKG.
Unknown downtime, he was sleeping in the hall.
Crash cart, let's go!
I got it.
They are putting the face mask with ambu bag for ventilation.
Hold compressions?
No! Defibrillation without checking the ECG? What if the rhythm is not shockable like an asystole or pulseless electrical activity? The defibrillation is used only for shockable rhythms of cardiac arrest like ventricular fibrillation or ventricular tachycardia, not for asystole or pulseless electrical activity.
Asystole.
It's a flatline ECG. Just do CPR and provide epinephrine and hope the patient has return of spontaneous circulation. During CPR, we look for ROSC or return of spontaneous circulation. This means when a patient regains a pulse signaling spontaneous blood circulation after cardiac arrest. It indicates that the heart has started beating effectively again. If after several minutes of high-quality CPR, there is no ROSC and no reversible causes found, then we consider stopping the resuscitation and declare death.
Resume compressions. Amp of epi. Slow tempo.
Normally, the rate of CPR is 100 to 120 breaths per minute. If you notice carefully, you can see his CPR movement is coming from his elbows, which shouldn't be the case. The elbows are not straight. The CPR also looks superficial, not deep.
I intubate?
No, drop an LMA. We don't want to hold compressions.
His airway is to be secured with an LMA or laryngeal mask airway. We discussed this in episode 1 as well. It's a device is placed over the patient's vocal cords. This is done so as to directly deliver oxygen into the patient's airway and minimize the work of breathing. The ambu bag would then be connected to the other end of the LMA, which is connected to this oxygen tube here.
Pupils are fixed and dilated.
It's been down a long time.
Fixed and dilated pupils means pupils unresponsive to light being shown and are unable to constrict. This indicates that the patient had no circulation since a while, meaning no blood supply to the brain, which caused hypoxic injury and death of brain tissue. Since it at least involved the brainstem, all brainstem reflexes, including the pupillary reflexes, are lost.
Take slow, deep breaths for me, Ian.
Ordered a neb, 5 albuterol, 125 solimedrol.
So, the patient is being nebulized with albuterol or salbutamol, which is a beta-2 agonist used to dilate the narrowed airways and help the patient breathe, also called bronchodilation. Solumedrol or methylprednisolone is a corticosteroid used to reduce inflammation of the airways. These medications are typically given to patients with either acute exacerbation of COPD or asthma. Both are diseases where the airways are inflamed and constricted.
Keep an eye on him and present to Dr. Langdon? Okay. Okay, great. I'll see you back in triage once he settles down. Yeah.
The patient is clearly in respiratory distress here.
Let's take this off. All right, hang in there, Ian. This should really help with your asthma.
We can give nebulization via mask or a mouthpiece like this. A mouthpiece would be more effective at delivery of drugs into the airway than a mask, which is usually reserved for young patients who are unable to use a mouthpiece.
We switch out every few minutes. You can take a break.
I'm fine.
Hold compressions.
Still in asystole.
Resume compressions.
Well, shall we shock him?
You don't shock asystole.
We could be fine VFib.
Not a chance.
Okay,
We discussed this just before. No shock for a flatline ECG. VFib could be shocked, but it's not the case here.
When was his last epi?
3 minutes ago.
Okay, well, ACLS says every 3 to 5 minutes, right? So let's push another round.
Fine.
We also discussed this just before. 1 milligrams of epinephrine repeated every 3 to 5 minutes IV to try to revive the heart.
3 rounds of epi and then call it.
Death is declared if there are no signs of life, no shockable rhythm or any rhythm whatsoever, no return of spontaneous circulation after multiple rounds of epinephrine and CPR.
Mr. Spencer's maxed out on BiPAP, 25 on 10.
Sats?
Not great, high 80s.
So the pressure in BiPAP was increased from 15.5 to 25.10 max to increase SpO2, which is still in the 80s after that. This is respiratory failure, and unless the patient is intubated, the patient would die shortly.
The alarm is for low oxygen.
Does he need more of that BiPAP?
I'm afraid that's as high as we go. So the decision at this point...
We want you to put our father on the breathing machine.
Even though that goes against his desires to not be intubated?
We as doctors have legal and ethical responsibility to honor what's said in the advance directive. Also, is this even legally allowed that the patient party could overturn a do not intubate in his advance directive made by the patient beforehand?
We're not ready to let go yet.
And if your father is?
He would never have given up on either of us. We're not giving up on him.
You're absolutely certain you want to put your father through this after everything I've told you?
Looking from the outside, it might seem like Dr. Robbie is being too cynical here, but he is actually being very rational. Intubation at the end stage of life, when the patient doesn't want it and has a legally written document not wanting it, isn't appropriate, both ethically and legally.
I may have to honor his advance directive.
Doctors are legally obligated to follow a valid advance directive, even if the proxy disagrees. The proxy can't override the patient's wishes. If there's a conflict like in this case, ethics committee consultation or legal review may be needed with an attorney. Here, the proxy is insisting on intubation against a valid DNI and is acting against documented wishes.
No, you have to honor our durable power for healthcare. If not, we can talk to your hospital attorney.
Durable power of attorney for healthcare is another legal document that designates someone who is often a family member to make healthcare decisions on the patient's behalf if they become incapacitated. The healthcare proxy can make decisions when the patient is incapacitated, but they must do so according to the patient's expressed desires or the best interests of the patient if those wishes are not clear. But if a DNI is part of an advance directive, like in this case, and the patient's wishes are clear, the healthcare proxy must respect this directive, meaning they cannot override the patient's decision to not be intubated.
Jeremy, you're on board with this?
Yeah, I guess so.
Okay, you can sit with him until we're ready.
When will that be?
Momentarily.
What? How? Am I missing something here? I don't think this is legally allowed. I am not a legal expert, but I do believe that durable power can't override a DNI legally.
Please don't tell me you're going to intubate that poor man.
It's what the family wants.
So what? They want to torture him?
I explained all that.
If I co-sign, we can override their durable power.
They're threatening to go to the hospital attorney.
Let them. Call the ethics committee. They'll agree with us.
No, you're probably right, but we don't have that kind of time. We are stuck.
The time is ticking, and with all the legal hassle, the patient could die in that time frame where a decision is reached. This is a tricky situation for doctors. However, I would stick with the advance directive and the DNI and let the patient party try to legally overturn the final wishes of the patient, if they can.
What are you talking about?
Shit. I gotta go tell those parents their 18-year-old son is brain dead.
This is the toughest and most difficult part of becoming a doctor, much more difficult than performing complex surgeries and operations. Usually, if the patient is an elderly patient with a lot of comorbidities or a terminal illness, the death is expected, and it's not as difficult to deliver the bad news as the patient party is mentally prepared. But the death of your child? When everything was fine yesterday and the child whom you grew up, nurtured, and had high hopes and expectations for in the future dies all of a sudden, that's the worst possible death of someone that you could ever experience in your life, living to see the death of your child. Add to the fact your child overdosed to a drug and left you behind. That hurts to experience firsthand. It also hurts to say it, and if you are in a specialty where you have to experience things like such and deliver bad news to the family every single day, like for example in neurosurgery or in the ER as well, it takes an emotional toll on the doctor and could lead to burnout and secondary traumatic stress.
You want me to come with you?
Nope. It's okay.
What are you going to say?
I'm going to say that it's likely, but we still need to do an apnea test and a cerebral perfusion study.
There's no cranial nerve activity.
Yeah, so the child who overdosed on fentanyl has death of brain tissue, including brainstem. The cranial nerve activity means reflexes involving cranial nerve nuclei in the brainstem. These are negative, as pointed out earlier, with caloric reflex test and pupillary reflex being negative. So there's no need for further investigations.
Activity.
Those people need some hope.
False hope.
Hope is hope.
Is it? What are we praying for miracles today?
They need time to process before they can accept what's happening.
Basically trying to buy some time for the parents to digest the bad news with investigations here.
No. People wake up from comas. You can wake them up. You can do that. You can talk. It's bad.
This reminds me of the time when I saw death of a young boy aged 7 who was admitted in the pediatric ICU for epileptic seizure overnight. Seeing the family's reaction to the death of their only child in the morning was one of the worst experiences of my life. This is the laryngoscope used in intubation, so he's prepping up the patient for intubation, not something I would do in real life.
No change.
No pericardial effusion, no tension, pneumothorax, no cardiac activity.
Let's try calcium. Could be hyperkalemia.
No, his potassium was normal.
They are trying to rule out any treatable causes here. Tension pneumothorax is when the air gets trapped in the pleural cavity and start expanding, leading to lung collapse. Pericardial effusion is fluid in the pericardial space, discussed in episode 1 as well. Hyperkalemia could cause asystole if the potassium is elevated to the highest levels. Could be treated with calcium gluconate, but it isn't the case here.
You ready to call this?
Not yet. Dr. Robbie said 3 rounds of epi. It's time. Let's push another amp. This one could do it.
I love how the young fella is hopeful for it. That's how you are, starting out as a doctor, but as you see more cases, you kind of see things quicker. Thanks for watching. Episode 3 is on the way, along with a ton of medical breakdowns.